Good afternoon. Welcome everyone to our very first virtual FEMAP tour at London Health Sciences Centre. We are delighted to have you all join us today for this very special behind the scenes donor experience to learn more about the first episode mood and anxiety program. FEMAP is a leader in adolescent mental health care and is one of the only programs of its kind in North America. Today, we're going to learn firsthand about how this unique program has helped change the model of care for youth and advanced academic research, all thanks to our generous donors. My name is Allison McCluskey, and I'm the Senior Development Officer at London Health Sciences Foundation. Together with my colleagues joining us here, as well as the FEMAP team, we're all grateful to have you join us. I'd like to let you know a few things about today's tour before we get started. First, everybody here is currently muted to protect the sound during the presentations. This session is being recorded. Today's tour will be divided into 6 sessions. So throughout the tour, if you have any questions, please feel free to write them in the Q&A chat button right at the bottom of your screen. And that way you can enter it in and we'll do our best at the end to answer all of your questions. So today I'm pleased to share with you our lineup of panelists. We will be listening and hearing from Dr. Elizabeth Osech, who will be talking to us about the evolution of FEMAP over the decade and a glimpse into the future. We'll also hear from Raquel Lopez, a day in the life of FEMAP's addiction and trauma counselor. We'll hear from Michael Wamis on the groundbreaking research and the impact of the pandemic on our youth. We'll also hear from Dr. Michelle No about training the future generation of healthcare professionals. Also joining us is Dr. Jennifer De La Paz, who will share a personal experience of residency training at FEMAP. And last, we have Shelley Sessions joining us live for a behind-the-scenes tour of the new FEMAP Riverview. Thank you again, all of our donors, our partners. Thank you so much for taking the time to join us today. And with that, to start today's session, I'm pleased to introduce you to Dr. Chanley Dickey. Dr. Dickey was appointed as the Chair Chief, Department of Psychiatry at London Health Sciences Centre in 2018. In her role, Dr. Dickey oversees mental health and addictions care across the city. Throughout her career, she has received a number of accolades, including Outstanding Psychiatrist Award from the Massachusetts Psychiatric Society, induction into the American College of Psychiatrists, and she was honored by Harvard Medical School through the A. Clifford Barger Excellence in Mentoring Award. Welcome, Dr. Dickey. Thank you for joining us.
Thank you, Allison, and I'm absolutely delighted to be here on behalf of LHSC leadership. So I am representing the hospital to you, and I want to start my comments by thanking you for coming today, for caring about our community's children and their future, for caring about FEMAP and wanting to learn more. It is really because of you that we are able to serve our youth. Our youth are very challenged right now. They were challenged before COVID, but it has gotten worse. We're getting many, many more referrals from families concerned about their loved ones, and the children are presenting with more serious symptoms. And so now more than ever before, FEMAP is central to our community and our ability to serve our young people. I'm very proud of FEMAP, as is the whole hospital. It's one of our gems. It is because it represents the best of our clinical and education and research missions here at LHSC. And I'll just highlight, you're going to hear many wonderful things about FEMAP, but I'll tell you what moves me the most. It is FEMAP, clinically, it's FEMAP's commitment and statement to every child or youth that comes through its doors, that they have complete belief that that child has the opportunity to get better and will get better. They don't give up on that belief. And I think that message to children is incredibly powerful. They think about what each adolescent or youth needs in order to get better. So all of the treatment plans are completely individualized. There's no cookie cutter here. And people look at FEMAP as a model for clinical care. They're pushing forward measurement-based medicine, which really improves outcome. Every piece of evidence-based way of treating our patients, they do. Now you're going to hear from Michelle No about education and Jennifer De La Paz about the education here. FEMAP is such an amazing training ground for our trainees. They're here, they learn about psychodynamic psychotherapy, DBT, how to connect with youth. I hear from trainees all the time how much they value their time in learning from these incredible clinicians at FEMAP. So not only is FEMAP helping today's youth, but also tomorrow's. And then research, you're going to be hearing about all of their innovations, but what I like is they flip research on its head. Usually, psychiatry has taken a diagnosis and has said, everyone with this diagnosis, let's see what they have in common. And it hasn't worked well. And under Beth's unbelievable leadership, they've sort of put that on the head and said, these people got better with this treatment. What do they have in common? What can we learn from each of these patients that we might be able to apply to another person? And that approach has been incredibly successful. And you'll also hear today how they pivoted to adapt to COVID, because COVID, as we all know, has really affected our country's youth. And FEMAP has done a great job in trying to understand in what ways has it affected our youth. But beyond its incredible academic mission, FEMAP is about our community. It's about our neighbors and neighborhoods. It's about our kids. And this gift that you help support to our community is really very, it's invaluable. Well, I've been talking a lot about what I love so much about FEMAP. I really just need to thank you, each of you, for caring about FEMAP, wanting to learn more, possibly getting more involved, because we know that no one clinic, no one family, no one entity is going to be able to solve the mental health and addiction issues that we are all faced with. And instead, we all really need to come together, bring what we have to share, and contribute together so that we can try to diminish the horrible plague of mental health illness. So thank you so much for coming and for committing your time today and for your interest. Bye.
Thank you. Thank you so much, Dr. Dickey. So let's kick off our panelists. I am privileged and pleased to introduce Dr. Elizabeth Osech. Dr. Osech holds the Rhea Chair of Affective Disorders and is the founder and physician lead at FEMAP. Dr. Osech went to Michigan State University's School of Human Medicine, completed her psychiatry residency training at the Shepherd and Enoch Pratt Health System in Maryland, and then finished a clinical research fellowship at the National Institute of Mental Health in Maryland. In 2006, Dr. Osech started FEMAP as a clinical research and treatment program, emphasizing early identification and treatment of mood and anxiety disorders in an outpatient and youth-friendly setting. Welcome, Dr. Osech.
Thank you. It's so nice to be here. And I do want to thank all of our participants for joining. I'm going to just share my screen here so I can kick off my conversation. And there we go. I think we've got it. So I'm just going to give you a brief introduction to the past, present, and future of FEMAP. Now, in order to do this, I have to put it in a little bit of a context. So this is a graph about the disability-adjusted life years from various mental illnesses. And disability-adjusted life years is just a way of understanding the impairment in function and disability that an individual experiences from the various mental illnesses. And what you see over here is a list of these conditions in the various lines represented here. Over on the y-axis, we have disability-adjusted life years in thousands. And along the x-axis, we have the age of the individuals experiencing these disability-adjusted life years. And what I want to bring your attention to is the heaviest hitters here are depressive disorders, drug use disorders, and anxiety disorders. And for the purposes of our conversation today, the other thing to bring your attention to is the fact that the age at which these lines peak, these curves peak, is really from 15 to a little over 25, 26, 27. And so if you're going to design a system that is going to most efficiently and effectively address the most serious impairment from mental illnesses, that's where one needs to focus. And that's exactly what FEMAP attempts to do. So as Allison has pointed out, FEMAP started in 2006. It started as a research program with sort of a clinical component added onto it. It was modeled after the early intervention psychosis programs in its basic elements. In 2009, we moved into a renovated youth-friendly house in the community, which you see here, which is where we are still currently located on 860 Richmond Street. In 2012, we became a recognized clinical program within LHSC, and that was because the amount of clinical care we were providing was significantly, a significant volume that it was obvious that we were a clinical program. And for those of you who may not know, I'm just going to describe a little bit about what characterizes FEMAP. It's aimed for the treatment of emerging adults age 16 to 25 with mood and/or anxiety concerns, either with or without secondary substance use conditions. Self-referral is allowed, so this removes one of the major impediments for young people getting treatment. We do not require a physician referral. We do not require a family doctor to send you our way. We have a multidisciplinary clinical team that involves both all the following: psychiatry, psychology, social work, family therapy, addictions specialists, and we provide group and individual treatment. There are no artificial endpoints of treatment. So we don't say, oh, you've got 20 sessions and that's it. You've got 5 sessions and that's it. And in fact, we don't even kick people out when they turn 26. And we are funded exclusively through research and donations, although I have an update about that, which I will inform you of when we talk about FEMAP presence. So when I designed the program, I had some specific things in mind, and this is the logic model of FEMAP. And these were the desired outcomes that I had in mind when developing the model. And there are 3 categories of outcomes. There are immediate, direct outcomes, long-term direct outcomes, and then indirect or ultra long-term outcomes. And so in direct outcomes, this involves things like providing direct access to mental health services, reducing emergency department usage, shorter wait times for needed mental health services, reduced suicide. For the long-term direct outcomes, we're looking at things like reduced functional impairment, reduced mood and anxiety symptoms, reduced substance use, improved quality of life, high satisfaction with care. And the indirect or ultra long-term outcomes, where you want to see fewer untreated youth with mental illness in our community, reduce school dropout and unemployment for young people in our community, faster recovery from mood and anxiety disorders, reduced suicide in the long run, reduced inpatient hospital use, and reduced cost of care. Now, because we do research at FEMAP, we've actually been able to demonstrate success at some of these outcomes. We have been able to show, of course, direct access to mental health services because we allow people to contact us without going through a family doctor. And as it turns out, our data show that 70 to 80% of the people who come to us come without a family physician referral. We've been able to demonstrate reduced emergency department usage in our clients. Our collaborator, Kelly Anderson, and the Department of Epidemiology and Biostatistics did a research project with us, showing that compared to young people with similar diagnoses in the community who do not attend FEMAP, the FEMAP clients have reduced emergency department usage. She's also demonstrated they have shorter wait times for needed mental health services. Reduced suicide is actually a little harder to prove because thank God, the rates of suicide are low enough that it requires tens of thousands of patients to look at that. But in terms of the long-term direct outcomes, we've been able to show that we have reduced functional impairment in our patients after treatment. We've been able to reduce mood and anxiety symptoms. We've been able to improve quality of life, and the patients have a high satisfaction with care. So as you can see, we are well on our way to demonstrating profound effectiveness of the treatment model. Just two examples of this to get into some details for those of you who might be data-driven or numbers people. In a study that involved 397 of our patients, we had looked at the Montgomery-Åsberg Depression Rating Scale before treatment started, which is shown here, and after treatment, after an interval of approximately 6 months to a year. And what we've demonstrated is that there's a statistically significant decline in depressive symptomatology in these individuals. And the red line here demonstrates clinically significant depression above the line and clinically not significant depression below the line. So we were able to get those folks to depression levels that were below the level of clinical significance, which is fantastic and what we'd like to see. Another and final example of that is the Shen Disability Scale, which is a measure of functional impairment. And again, we see that the functional impairment when people come in pre-treatment is quite high on this scale. And by the time of post-treatment or the 6 to 12 month interval, it's greatly reduced statistically. And it's also, this line indicates clinically significant improvement. So that's exactly the kind of result we want to see in a model to treat young people. So moving on to the present, as you know, we had this COVID thing, which interfered with a lot of our normal functioning, but we've still been seeing patients during COVID, and as of a weekish ago, we were seeing 50% of them in person and 50% of them virtual. And obviously, as the lockdowns ease, we hope that most of that will go back to being in-person care. We were able to have one in-person group, and that was our stabilization group for trauma-exposed young women. And that was very much valued by our young people. That occurred between wave 1 and wave 2 of the pandemic. If you recall, there was a time when we were able to meet in small groups. And of course, we've been able to conduct research during the lockdowns. So one of the aspects of the research is we devised a way to monitor the individual responses of our patients to the pandemic because we were quite worried about them. We wondered how they were doing with all this. So we were able to identify ways to get alerted if they had symptoms that were concerning without actually making individual contact with them. We have one paper that's been published on that study so far. We've also evaluated symptom severity and functioning pre-pandemic versus post-wave 1. And we're also going to analyze, we have data from wave 1, wave 2, and wave 3, and we'll look at the progression of symptoms across those time points. We've got one publication under review for that, and one is planned. We've also got some qualitative data where we asked the young people to describe some of their experiences during the pandemic. And we've recently submitted one paper that presented that data, and we're in preparation for another one. Some other good news about the present, we actually received our first ever ministry funding, and that was end of year funding. It was earmarked for the year 2020 to cover some of the operating costs of FEMAP, and that is fantastic. That's a true milestone because that is the first time we have ever received any ministry funding for the program. Unfortunately, of course, it has not been deemed to be recurring as of yet. However, another piece of good news out of the present, our VP of Mental Health, Tom McHugh, brought us to the attention of the Ontario Centers of Excellence. He gave a presentation about FEMAP so they would be aware. And they're the people who plan systems healthcare across the province. So that's very good news. On the not so good news side, requests for services of FEMAP have increased 100% in the last year, undoubtedly because of the pandemic. In the future, however, we're looking forward to expanding to a second site, and that will hopefully mitigate some of that 100% increase in requests for care. We hope to be able to double our capacity clinically, so that could reduce our wait times to something way more manageable actually than we've had in a long time. And so for some of the details on that, we are going to be working with our patients to design new programming. And before this third wave hit, we had organized some focus groups to meet with our patients to talk to them about what they'd like to see by way of programming and what would be most helpful for them as we expand moving forward. And that obviously had to be delayed because of this last wave, but we will be picking up on that again. Additionally, we're going to be implementing measurement-based care as a software tool, and this was developed in Australia. And this is going to be very helpful for us because what it will do is do things like help us expedite triage of the most urgent patients if wait times exist by identifying who is actually undergoing the most distress and needs to get in sooner. It will facilitate an even more personalized care plan for each of our individual patients. It will be able to identify someone who is worsening in their status in terms of symptomatology and assist by automatically feeding management tools, online apps, and that sort of thing that can help them with those symptoms. And by identifying someone who's worsening, we'll also be able to modify or step up treatment as needed in a step care kind of model. And we'll be able to confirm when a patient is recovering, and then that will help us be able to step down their treatment requirements and make room for another person who needs to come in for care. So we're looking at a very exciting future. And I hope that that's the last of my slide. I hope this has been helpful. And I would encourage anybody with questions to please put them in the Q&A section of the chat at the bottom of your video. Thank you.
Wonderful. Thank you so much, Dr. Osach. Thank you, thank you, thank you. And we're excited. We're excited for the future of FEMAP. So thank you for your presentation. And as Dr. Osach mentioned, just a reminder, please feel free to enter questions as we go and just enter them in the chat, and we'll be happy to answer those at the end. So next up, I'm pleased to introduce you to Raquel Lopez. Raquel will be talking to us today about a day in the life of FEMAP's addiction and trauma clinical counselor, caring for FEMAP's clients. Raquel has over 25 years of experience in community development and services for populations at risk due to adversity. Her experience includes providing trauma-informed substance dependence assessment, counseling, treatment, and referral. She works with victims and survivors of domestic violence, sexual harassment, sexual assault, sex trade, and sex trafficking survivors. Raquel is a lifelong learner and is a proud member of the FEMAP team for the last 7 years. Welcome, Raquel.
Thank you. I hope you can hear me.
Yes, we can hear you.
So I'm going to set up to show our screen. I'm really excited to be able to share some of my experience working at FEMAP. So I'm going to go straight to the screen and just share some slides in case we don't have enough time. So hopefully I'll get this done right. And I think people can see that. Let me know if you can't see it. So part of my role at FEMAP has been to be able to do some work with people who have substance use and trauma. And I'm going to walk you through some of the work that I'm involved in doing here. So about 8 months ago, I got hired full-time after working part-time for about 6 years at FEMAP. And in that time, I have received 56 referrals from people who have been impacted by substance use and trauma. Of the referrals, 70 to 80% of those clients that I see for substance use have both developmental and complex trauma history that has often gone untreated until they have been seen at FEMAP. For about 20 to 30% of those clients, their current mood and anxiety issues and symptoms relate primarily to their substance use. About 80% of those clients might be of interest to you to know happen to be white Caucasian clients, mostly born in Canada. And about 16% of the clients that I see are clients who are actually reporting concerns around their sexual identity issues. In terms of the services that I offer on my day-to-day kind of work, I do trauma treatment, I do assessment, treatment and counseling for substance use and substance dependence. I work at providing and practicing with clients in office, in person, and on the phone or online. Coping skills and strategies that include grounding activities for those who experience flashbacks, nightmares, panic attacks, and other post-traumatic stress disorder, physical and emotional responses. I'm also qualified and certified to provide vaping and smoke cessation treatment. And in terms of medication, that's the one part that I don't handle. So that goes back to our psychiatrist and or to their family physicians in the community. I provide counseling sessions on healthy relationships, which seem to be a huge challenge for a lot of our clients, as are healthy boundaries. I do a lot of linking to and referral to community resources, particularly around finances, housing, crisis management, 24/7 addiction and mental health supports, shelter beds, crisis beds, as well as personalized crisis and safety planning for some of the life areas that the clients are struggling with. I provide referrals to residential treatments when those are appropriate and when the level of intensity of treatment is beyond what we can offer a particular client who's struggling with severe substance dependence. I also do education and support for those who are not ready to change. So sometimes in our team, people wonder if I can see people who don't want to change, but who are identified as having substance use. And so we call those clients recontemplators, and I do see quite a bit of that as well. Other services offer, I do counseling and support and safety planning for clients of ours who have been involved or are contemplating entering sex trade, which is a challenge in our community, as you probably are aware from news and social media. Lots of young people, particularly young women, including university students, are lured into quick ways of making money by providing sexual services or sexual-like services online and or in person to mostly adult males within Canada and outside of Canada. I also do counseling and support for sexual assault, including support around somebody who may want to report to the police that they have been sexually assaulted. And when they choose not to report to the police, providing them with the support around increasing their safety and addressing their trauma impact. I do quite a bit of counseling actually around sexual identity issues, because we have a chunk of our population who have also identified having sexual identity concerns. I also do referrals to the larger community for LGBTQ and two-spirited clients, as well as referrals for employment around this time of the year, particularly helping clients, even under COVID, connect to supports that are sensitive to their mental health, sensitive to their substance use history, sensitive to their trauma history, and who are willing to or interested in supporting and employing youth. I connect them to supports and connections around volunteer services in the community as well, because sometimes that helps reduce isolation. Even during COVID times, there are opportunities for people to help others out. And often one of the things that clients identify is that they lack social support and experience a great deal of boredom. So connecting them to social supports that are cost-free or near cost-free in the community. In terms of some of the future goals that I see myself and our team focusing clinically on, there are things like being able to offer, once we expand, not currently because we neither have the space nor the staffing, but really being able to offer coping skill groups for people who are early in identifying their substance use desire for change and concerns, as well as enhanced relapse prevention for those who are maintaining abstinence and are beginning to identify that they're concerned about their potential for relapse. For people who drink, summer is a huge trigger, and so this will be something that will help people prepare for what to deal with through the seasons of their triggers in substance use. One of my other dreams is to be able to offer more trauma-specific treatment for clients in our population, both male and female, in terms of the impact of trauma on their physical, mental, and emotional health. So things like a program called Seek and Safety, which has really been developed and validated to provide group support as well as individual support. Being able to do a manualized group called Beyond Trauma, and also being able to train and do some work around cognitive behavioral therapy or dialectic behavioral therapy as well. My dream is also that we can offer at some point in time, when we expand again and we have the space and the staffing and the resources, one-time workshops on topics like healthy relationships, developing boundaries, communication skills, conflict management, and definitely managing boredom, which has been a huge issue for our population currently. One of the other things that I hope that we will be able to have as well is an opportunity in our expansion to cross-train with other hospital teams so that we can share our clinical resources as well as our group facilitation. So that's kind of like some of the stuff that I imagine, hopefully, that we will be able to have. One of the things that I didn't mention in the slides is that part of my role in coming back to work for FEMAP when I was hired full-time was also to take on 50% of the intakes that come into FEMAP to be screened for appropriateness of service. And this might be of importance to you. In the 8 months that I have been here working full-time, between Mike and I, we split up the number of intakes that we conduct on a biweekly or a weekly basis, sorry. And I was totaling yesterday or today the number of intakes that I have had to do since I arrived at FEMAP. So on top of all of the things that I just described to you that I do in my role as a clinical counselor here, I have also provided and conducted 53 intakes, which usually take between 1 to 2 hours. By the time the paperwork is done, is usually 2 hours. So to me, that's a significant number of people that we have been able to screen in. Mostly, I don't think we've screened anyone out of, maybe one person out of our services out of those 53 intakes that I've done since October. And my client caseload is also fairly active. So at this point in time, of the 56 referrals that I have had in total since I started, about 36 of those clients are active, ongoing clients, and about 16 of those are what I consider inactive when they don't attend as consistently or as frequently. Again, as Dr. Osich mentioned, there is no end date to when we stop seeing someone. We make those decisions together with our clients and with our team of clinicians in terms of when it's at a good time to begin to look at discharge planning with the client and with the rest of our team. So that gives you a little bit of a glimpse of what my day or week looks like. And if you have any questions, please type them into the chat box and we will respond to them at the end of today's presentation. Thank you.
Raquel, thank you so much. Wow, thank you. That was eye-opening, and we're so grateful for your passion, for the care that you provide. And again, we're so grateful to our donors for your support. And you can hear, you know, the vital role that Raquel plays. So thank you, thank you. So up next, I'm pleased to present Mike Wamis. Mike has worked as the research coordinator at FEMAP since 2012, but has worked in mental health in both research and direct service provision for over 15 years. Mike has a background in cognitive neuroscience and is also a registered social worker. Mike supports and helps manage all research projects at FEMAP and has also co-facilitated the FEMAP Social Anxiety Group in recent years. Today, Mike will be talking to us about current FEMAP research projects, particularly one related to the COVID-19 pandemic. Michael, welcome. Thanks for joining us.
Thank you. Let me just see if I can get my slides going here. Hopefully that's visible to everybody. There we go. Yeah, so since research is such a big part of what we do here, we thought it'd be important to kind of share maybe not a ton of detail, but just the wide range of types of research that we engage in here. So because FEMAP is such a novel treatment model, it's been critical that we evaluate the model to make sure that we're actually doing what we say we're doing and what the model was designed to do. We basically ensure that patients can navigate the model and monitor their outcomes kind of as they navigate treatment. It turns out, as Dr. Osach showed at the beginning, that our patients do indeed improve over time and that they are on average also very satisfied with their treatment here at FEMAP. We also think that it's pretty important to take into consideration the cost of FEMAP to the healthcare system. We're currently doing an updated analysis of that. But a preliminary analysis from a few years ago showed that indeed FEMAP is cheaper to the healthcare system on many metrics than some of the alternatives that our patients might find themselves in. Over the years, we've also looked at, we've also done several different brain imaging studies, looking at the impacts of cannabis use on individuals with depression. We found that the combination of those two things seems to alter functioning of the reward neurocircuitry in the brain, and also ability to regulate emotions. We also looked at non-suicidal self-injury and found also differences in emotion regulation areas of the brain in individuals who engaged in non-suicidal self-injury. We've been, over the last several years, working on a series of studies attempting to understand any brain differences between people who are diagnosed with bipolar disorder and people who are diagnosed with depression, since this remains one of the biggest diagnostic challenges in psychiatry, especially with this age group where mental health issues are just starting to emerge. So we're working with collaborators to create an algorithm to hopefully help predict which diagnosis an individual might have just by looking at their brain, or more recently and more importantly, what medication might best help get them better, if any. This was also alluded to a little bit earlier, but we've done a series of qualitative studies over the years as well with our patients. So basically, conducting interviews with them and then looking at what they say for common themes. So across several studies, we've asked our patients, what advice would they give to other new patients entering treatment? What has helped them throughout the course of their treatment and what has kind of gotten in the way? What they expected treatment to be like before they started it versus what the experience was actually like once they walked through the door and engaged in mental health care. We've also looked at our text message communication with our patients to ensure that they were using that tool appropriately, which was a common fear of implementing that technology. And we're currently working on a study on the concept of human dignity and what that means to our young people here. Because historically, that's a concept that's largely been studied in like end of life and geriatric populations. And COVID-19, like everybody, we had to pivot when COVID hit. Dr. Osach alluded to some of this in the beginning as well. We were concerned that our patients would be struggling with the isolation and limited access to care. And we were also kind of limited in the types of research that we could conduct early in the pandemic. So we created this monitoring and flagging system where we predetermined what scores on some of our questionnaires would be concerning. And then we designed a system that would alert us if our patients scored above that. And we gave our patients the opportunity, even if they didn't trigger a flag, to indicate whether they wanted someone to reach out to them if they felt like they needed urgent support. And a lot of our patients took us up on that and engaged in that system and found it beneficial. And it was useful for us to kind of triage what patients needed the most care during that time as well. And so, yeah, they just filled out questionnaires on a regular basis and then let us know how they wanted to be reached, if they wanted to be reached. And then we did that. So as Dr. Osach mentioned, we published the initial monitoring study, and we're preparing some papers on the early impacts of the pandemic on our patients, and then also a qualitative study where we asked them to kind of forecast potential negative and positive outcomes of the pandemic. So it's been really interesting analyzing that. Never a dull moment around here. So we do have some new collaborations upcoming. One of which is looking at how gut bacteria might be involved in some of the weight gain side effects to some psychoactive medication. One is looking at the impact of adolescent nicotine use on potential mood and anxiety symptoms. And as was also mentioned at the beginning, some sort of evaluation of this measurement-based care platform that we're hoping to implement. So that's it for me, but genuinely thank you all for being here and donating. You know, donors kind of make what we do possible, and we wouldn't be able to do some of the more complex care and cool studies that we get to do without donations. So thank you all very much for being here.
Wonderful. Thank you, Mike. Thank you so very much. And just to add to that, there'll be a special article coming up in our brand new Summer Impact magazine, hot off the press, that does include a beautiful feature on FEMAP, and we'll have some more additional details related to the research that Mike has just gone over. So Mike, thank you so much. Up next, I'm pleased to introduce you to Dr. Michelle No. Michelle is going to talk to us today about training the future generation of transitional age healthcare professionals. Dr. No is a child and adolescent psychiatrist and has worked at FEMAP for the last 9 years. She is the program director for the Child and Adolescent Psychiatry Subspecialty Residency Program at Western. Dr. No often supervises residents and medical students and enjoys integrating her role as an educator into her clinical work at FEMAP. Welcome, Dr. No.
Thank you so much, Allison. I'm going to just share my screen and get started. Hopefully going to come up soon. So I'll just start talking before it comes up anyways. Here we go. Good. Welcome everyone to training at FEMAP. I'm really thankful that the foundation put this together today so we can showcase some of our work, and I'm really happy to share it. Today I'm focusing on medical trainees. So these are our medical students, psychiatry residents, and child and adolescent psychiatry residents that come through the house. We do get lots of requests to train other health professionals as well, mostly social work and psychology interns. And we really hope with the expansion and the new site, we're going to be able to accommodate a lot of those requests as well. So as you've seen, this is our house. For those of you that are visual kind of people and need to know where we are, This is my office up here in the top left of the corner of the house. And I want to take you inside and show you around a little bit. So I often get this from people. People sort of say to me, Michelle, I would really like to kind of be just like a fly on the wall in your office and observe and kind of hear and see what goes on in there. And so that's the kind of experience I want to try to create for you today and give you an idea of what's going on here. So you heard from Dr. Dickey already, but I can't emphasize this enough. When the trainees choose rotations and clinical experiences, because they do have choice, they are looking for what we would call kind of like the triple threat in medicine. So they want to be in a place where there is excellent clinical care for patients. They want to be a part of that. A facility that is conducting research and asking the tough questions and moving the art of our discipline forward. And they want a good training experience. They would like good supervision and be able to grow as psychiatrists and really fulfill their potential that way. So this is sort of the draw that we're seeing to our program for the trainees. But that's not really it. There's a lot more going on as well. I have to say, I think the trainees are really drawn to our patient population, as we all are as well, those of us that work here. So at 16 to 25, there's so many things that are going on, right? These are major milestones for people at this time in their life. There are lots of firsts. And to be a part of working with somebody at this stage in their life is really, really meaningful and can be really impactful. So I know a lot of trainees come just because of our age group and what's going on here that way. The other big thing is how much psychotherapy we're doing as well, and the breadth of psychotherapy that's happening. So we're very lucky. I think all of the psychiatrists in our program, we all have a strong interest in psychotherapy. We integrate it into our work. And it's a very seamless sort of integration between medication and psychotherapy management. So the trainees, they want to see that model of care, right? They want to be able to experience it firsthand, because residency training is really about trying things on for size a little bit, right? They want to see what their practice could be like and what practicing in this setting could be like. So that's another big draw as well. So I want to just walk you through a little bit of what training looks like and what I'm talking about year by year. So I've put together this kind of picture representation of training. So each one of these symbols here is 1 year of a trainee's life. So, you know, I'm going to walk you through from left to right. So, so first off, of course, you're doing an undergraduate degree at a university. That's typically 4 years. Then you head into medical school, another 4 years. And then we head into what I'm showing you here is the brain stage. So that's 5 years of psychiatry residency training. And then if you are really keen, then you join me in my program and you do two extra years to become a child and adolescent psychiatrist and do that subspecialty training. So let me walk you through some of the color coding that I've done and give you some highlights that way. So we'll start with the purple stage. So lots of our trainees are currently coming through in those years that I've identified. So that's the 5th and 6th years of training. These residents, when they come through, are already very highly skilled. This is the end of their training. They're really independent. They want to know at this stage the nuances of what it means to work with transitional age youth. And so as an educator, it's really rewarding to work with these residents. It's challenging, and I really love that. So often I'm trying to work with a resident and push them from being good to great, or great to extraordinary. That's the sort of thing going on here. And they come through, you know, for a good chunk of time too. They're here with us for 3 to 6 months typically, and really get immersed in what we're doing and get the true FEMAP experience. The other stage or year that's commonly coming through our program is right in the middle of residency. So during their child and adolescent psychiatry rotation, they may come through our doors as well. and maybe do a psychotherapy case that year. That commonly happens, and really get an introduction to working with young people. So next I'll highlight some of the yellow staged years that I've identified. So third year medical school and first year residents. So I've identified there that they only come through sometimes through the house. And that's because simply we get so many requests and so much interest in coming through, and we can only sort of accommodate so many trainees at a time. So unfortunately, these are sometimes the years and the trainees that we have to tell them we can't accommodate them. And as an educator, that's heartbreaking to me to have to say no to these individuals. It's like, it's only second to, you know, having to turn down patients for patient care, basically, because they've heard about FEMAP. You know, if they've been at Western for a little while, they may have heard about our program. They kind of want to get their foot in the door. They want to experience what's going on here. Often the senior residents will sort of tell them about their experiences as well. So I think what's been happening over time is there's a bit of a buzz and a bit of an interest and a draw, and people feel like they will miss out if they do not get some training at FEMAP at some point during their residency. So the last thing I wanted to highlight on this slide is just the green brain stage, which is the second year of residency training, because this is a brand new experience, an elective experience that we're putting together for second year residents that is going to roll out with the new site. We hope to be able to bring in more residents at that stage to come visit us weekly, come follow the same patients, and get a longitudinal experience that way. So, so just to put some numbers and some faces to who I'm talking about here, in our general psychiatry program, we're probably training about 40 residents altogether. And our subspecialty program is a little smaller. We typically have about 4 residents. So pictured here, we have 6 residents. That was a big size for us that time. Of course, this picture was taken before COVID a couple of years ago. And I just want to highlight that, you know, with our program straddling the age range between pediatrics and adults, we've really gotten a lot of interest from both sides, from people training that may end up being an adult psychiatrist, but really want that extra experience working with young people, and then child and adolescent psychiatry residents that want more training into early adulthood as well. So, and just to kind of let you know the interest amongst this group, because there has been a lot more interest within our child and adolescent psychiatry residents recently. Of the 6, 5 of them ended up coming through FEMAP to rotate with us, and which we were thrilled about. But what was even a better result, I think, and really something we're so thrilled about, is the fact that 3 of them upon graduation ended up coming to our program and becoming part of our staff and working with us. So take a look at the faces. You might recognize somebody coming up as well. So just to kind of give you a bigger picture and zoom out a little bit more, probably in about a year, we would train, say, about 25 child and adolescent psychiatrists in the country, across the country. And so when I think about 3 of our graduates coming out of our program and then choosing to stay at FEMAP and working here, that's relatively a pretty big chunk of the pie, right? So we are really happy with our retention rate and what's going on that way. So I just wanted to wrap up by thanking everyone for joining us today. This is our new site. You know, our new site is going to have new trainees, or more trainees, meaning less waiting and more patient care. I've heard so many grateful comments from patients over the years that I want to be able to share with you. You know, patients will say to me, it was worth the wait. That's what I tell all of my friends and roommates and coworkers that I send through and refer to our program as well. They really can't believe it's free. They're thankful for that, and they're happy to say that, you know, I think everybody should do therapy and experience that as well. So I just can't thank you enough, and we always we need your support to be able to do this amazing work. Thank you.
Thank you so much, Dr. No. That was fascinating. Thank you, thank you. It is exciting to see how the residency program is growing, and especially with expansion and just the importance of training the future generation. And so, as Dr. No mentioned, you will probably recognize our next panelist from the photo in Dr. No's presentation. So I'm pleased to introduce you to Dr. Jennifer De La Paz. Hello there. So Dr. De La Paz is joining us from the FEMAP house. She's going to be talking about a personal experience of residency training at FEMAP. Dr. De La Paz majored in personality psychology in her undergrad degree at the University of Toronto, then worked as an English teacher in Japan for 2 years, followed by completing medical school at Ross University's School of Medicine in the Caribbean. She went on to complete residency training in general psychiatry, followed by training in child and adolescent psychiatry at Western. She is the newest psychiatrist on the FEMAP team, and her main clinical interests are transitional age youth mental health and youth addictions. She's excited to have joined FEMAP this year to work with the young people in this community. Welcome, Dr. De La Paz.
Hi, thank you for the introduction, and I hope that you guys can hear me okay. I'm here really just to offer kind of a mirror to everything that has been said before me, especially the last talk from Dr. No, just to kind of reflect what my experience was as a trainee coming through FEMAP. So my start with FEMAP was actually towards 5th year. I had wanted to join to do a rotation here in PGY3, but unfortunately there was no availability because it's really just that popular as a rotation for the residents here. I was lucky enough to also work with Dr. No for my rotations, but also Dr. Osich for my research. So it was really attractive to me to be able to come to a program that was so unique in its vision and its mission in working with transitional age youth, but had a very strong clinical piece, both psychiatric and psychotherapy, but also a very strong research piece. And when I actually came here in PGY5 to do a short rotation, I decided that I really love the atmosphere so much, just in the house, in the program, and the kinds of clients that we see, to the point where I thought, you know what, I want to do an even longer rotation. So in my 6th year, my final year of my subspecialty training, I did a longitudinal rotation from about November 2020 until pretty much June last year when I finished my residency training. And that really gave me an opportunity to see the whole journey, both of the clients who come through here, but also of what the clinicians do, what the psychiatrists do, what the research staff do, and really our admin support. And you don't have anyone on our panel today who represents the admin support, but they're such a critical part of the team as well. And they're so essential to how cohesively this program works. And I think that's something that really struck me as a trainee, is how much FEMAP is an interdisciplinary, truly interdisciplinary program. I haven't seen anything like this, pretty much any other program that I've trained in, both here at Western and non-elective at other programs. Everyone works so closely here together, and it's really amazing to learn from everybody who's here. So I had my clinical rotations with Dr. No. She directly supervised my interviews. She gave me feedback right after my interviews. As I got more comfortable with the clinical care, she gave me the autonomy to start working with the clients or with the patients one-on-one, and would always have regular supervision with me. So I never felt like I was alone. I never felt like I was unsupported. But the same with the other people in the house. I worked with Dr. Osich and also Mike on my research project throughout my psychiatry residency, and being very naive to research when I started out, it was really helpful to have people with so much expertise to guide me. And especially because I was working on neuroimaging, which again was so exciting and interesting to me, but so also foreign. I learned a lot just about the process of doing research and the process of learning about all the intricacies of neuroimaging and how to really apply that clinically in the population that we see. And I was lucky enough during my rotations here to also work at times with Raquel, hopefully she remembers those times I got to sit in with her, with some of her clients. So it was actually really nice to see a different side of mental health care, because when we're doing kind of strict psychiatric sort of rotations, we don't always get a lot of opportunity to work with the other allied health professionals that are also so essential to the treatment programs. And so being able to see her approach to working with youth with addictions really helped inspire me to incorporate a lot of her techniques, a lot of her strategies, and engaging youth. And I think that's one of the biggest things that is a draw for FEMAP, both for patients, but also for trainees, is the engagement with the clients here. It's so embedded in the community and so receptive to feedback from the patients and from the team itself. It's continuously evolving, continuously improving. I think that is really exciting to me, because everything kind of in-house kind of feeds into the further improvement of the program. And I love that it's a low barrier program. Again, I haven't worked in many other programs or trained in other programs which allow youth to refer themselves. And I think during this developmental stage, it's so critical that youth can take ownership of their treatment. This is sometimes the first time that a lot of the youth have come through without their parents. A lot of the patients that I saw as a trainee and now as a member of the staff say that, you know, they don't know how to even fill up prescription because they've never had to do that on their own. And the people here, everybody on the team, makes it so accessible and so welcoming that it's not scary to seek your own healthcare. And I think that's really empowering for the youth that we see here. It really sets them up to be more successful as independent adults when they get that sort of treatment experience. And it makes such a big difference in how well they can engage with healthcare going forward. So I think everything about how FEMAP works as this kind of cohesive sort of machine, but also is very personal. It's not cold here. You see people in the hallways, at least, you know, before COVID, without masks. And you get the feel like people are happy to be here. People are happy to work here. People are happy to get treatment here. You don't often get that feeling from clinics. And I think that's what's really nice about FEMAP. It doesn't feel as clinical, even though we do really good clinical work here. I think I really wanted to be part of that once I graduated and wanted to pursue my own kind of career path. This is the kind of model that I think I would really thrive in. And so far, I'm very new as a member of the team, but I really do feel a continuation of the atmosphere that I had as a trainee, with how welcoming and how engaged and how enthusiastic everyone is here. And I think the youth who come here really notice that as well. And it makes it a big bragging point for our academic program. Both as a resident and as a faculty now, I've worked on the CARMAS committee for recruiting medical students to the psychiatry program. And also I helped to recruit trainees to our subspecialty program. And talking about FEMAP, it's very easy to brag about because it's just, I mean, it's honestly just such a good experience and it's so unique. There's, like, as you heard earlier, there's very few programs like this all across North America. Everyone has heard about early intervention for psychosis, but no one really realizes how much burden mood and anxiety and trauma and substance use really has until they see the outcomes 10, 20 years later. So the fact that we have a unique program like this to really focus on that early intervention is so special. And it really is a big draw, I think, for medical students to the residency program and for residents to the subspecialty program. And I think I'm really lucky to have been able to come through this. So that's all that I really wanted to say, just to kind of give a really personal experience of how amazing this program is. And I hope that everybody who's listening today feels inspired as much as I was.
Wonderful. Thank you, Dr. De La Paz. Thank you. And we're lucky to have you. We're so happy you're a part of the FEMAP team now. And thank you for that, because I think it really gave us a lot of wonderful details about how closely you do work as a team and, you know, how that positively impacts our clients. So thank you very much. So up next, we have an exciting part of our tour. This is actually the last part of our session today. Since the opening of FEMAP many years ago, as we've heard, we've been running out of the FEMAP house on Richmond Street. So as we know, the current space is at full capacity, which limits the ability for the program to grow and meet demand. So today we are thrilled to give you an exclusive behind the scenes tour of the new FEMAP Riverview, currently under renovation. This will be the second home for FEMAP and will allow the program to enhance care for more clients. So we are so grateful to donors who have supported, our partners, everybody who has made this wonderful milestone possible. Thank you. So broadcasting live from FEMAP Riverview is Shelly. So Shelly's joining us live in front. Shelly's our project consultant with London Health Sciences Center Facilities Management. Shelly's the project manager overseeing the design, development, and construction of our beautiful new space located at 54 Riverview Ave. So welcome, Shelly.
Hi, everyone. I hope you can hear me. It might be a little muffled with the mask on. Welcome to 54 Riverview. I'm delighted to be here to show you an insides behind the scene of the new FEMAP space. We are set to open at the end of the year, so it's very exciting that we're able to expand this for the FEMAP program. As you can see the building outside, it is an owned LHSC property, and it is shared with some other LHSC and CMHC programs. So FEMAP's going to be an essential part to this, and it's very exciting to see that. The location was also selected as it's just off of Warncliffe Road South. It is definitely easy to access via public transportation for any youth that are coming. And we definitely have some availability for parking as well on site, which I know is a huge asset compared to the existing location at Richmond. So another huge perk for anybody coming to FEMAP is we are in a residential area. And as you can see, the beautiful mature trees, the quiet streets, it's very relaxing for anybody that would be coming to the FEMAP location. All right, so let's head inside. So anybody who will be attending FEMAP, you will be coming through the main entrance here. Once we're in the entrance, we will be utilizing some resources within the building. We have a shared secretary or reception area, sorry. She locked us out. Oh, there we go. All right. So as we walk through the main entrance, we will have the reception area here that will be shared with the other areas. The building is also equipped with an accessible washroom and an elevator. So we're able to accommodate everybody that does attend the FEMAP program. So we'll just head right to the level 2 area, or the level 1, sorry. So this level 1 space is going to be a big overall improvement for the FEMAP program. The space is going to have a dedicated secretary space, a shared clinician office, as well as a group room. So this will be the secretary space here. This level 1 is yet to be under construction. We are doing the construction within 2 phases. Sorry, bear with me here. Oh, looks like we can't break in. All right, so this will be the shared clinician's office here. It's got some natural light, some large windows. So I think it'll be a very nice space once it is opened up. And then further down the hall, we will be doing some renovations, putting a new door, providing more access into this open space. The space right now is currently being used for training. Once we do the renovations, this space is going to be turned into the group/team room. So this is a big benefit for the new FEMAP program. We're going to be able to do some great group sessions in this space. We're going to be able to have movable tables, as well as installing a 75-inch TV for presentations, for training purposes, everything like that. We will also be adding in additional swing offices in this location. We will be building a wall here. Access from one office will be off the group room. The other one will be off the corridor. The very unique thing for the one swing office is we will be installing a two-way window. That two-way window provides excellent opportunity for training, and it will allow that either the group area or the dedicated space to be observed from either setting. So you'll be able to do some residency trainings within this space so that you can observe any of the private sessions that are going on and vice versa. So that's something that's very excited that we're able to provide to this space as well. So that's all for level 1, and then we'll head up to level 2. Sorry if you're a little dizzy watching us go up the stairs. So level 2 is the area that is currently under construction. So level 2, as you can see, we are in construction here. Everything is going very well. We are currently on schedule, which is excellent. So this space will provide us with a conference room, some shared office space, some dedicated private office space, as well as collaboration and research space, which is very exciting for the program. So right now we are just looking at some demolition work. This space here is an example of one of the private offices that'll be shared with the clinicians, the residents. So we've got all new furniture that's been purchased for the project. And thank you so much to all the donors for their input on the selection of the furniture, the colors. The entire space is going to be painted a very nice pewter color. And the accents are a nice green and blue, which are very calming for the program, which is excellent. Each room will have their own accent color, so they are not going to be all the same. As you can see, the space also offers some beautiful large existing windows, which are going to remain here, which will also be the benefit of providing that natural light for everybody within the space, for patients that are coming to this space. We are trying to make sure that everything is very calming and inviting for anybody that would be visiting the FEMAP program. This office here is the private physician's office. So as you can see, there's more demolition work that is happening in here. As well, we'll make sure that everything is that nice, lovely color. The existing floors are going to remain as they were in excellent condition, with some nice patchwork that needs to be done, new ceilings, lighting. And again, the natural light itself, it's a huge benefit for this location. This space here is going to be an excellent addition to the program as well. This is the collaboration and research space. So we will have space to allow for 6 workstations within this area. It's a great space for research staff to collaborate, as well as what's being framed in right here as well will be a dedicated dictation area. So this area will allow for physicians to have an area to record any confidential information regarding their sessions. All right, that seems to be the extent of their renovations. Thank you very much for joining me through this. I appreciate all the donations that have come in to support the entire FEMAP program. I think they do an excellent job, and I'm definitely excited to be a part of it and then ensure that we do have an expansion to be able to support the need in the community. Thank you so much, and I hope you enjoyed our walkthrough.
Wonderful. Thank you so much, Shelley. Thank you. That was so amazing. It's so exciting and inspiring. And again, we can't thank our donors enough. It's such a beautiful new space. And as Shelley pointed out, there's just going to be so many opportunities to expand the program. So thank you. And so with that, I'm going to invite Dr. Osuch to join me. We did have a few questions that we will answer before we conclude. So
I do want to say how wonderful it is to hear my team speak so highly of our program. It's really fantastic. It's heartwarming for us all, I think, to hear, because we don't, I mean, the COVID thing, I mean, we don't do this every day. So that was really fantastic too.
Yeah, wonderful. Well, Dr. Osuch, one question that we have received, how long is the current wait time for patients to participate, and how do you triage your intake?
So I think Mike actually has the more accurate answer about the wait times. Mike, are you still around to answer that question briefly?
Yep, I'm here. I mean, it's not great right now, to be honest. It's about 6-month wait to have an intake assessment. And then from there, depending on, because again, it's not a one-size-fits-all model. We kind of decide, the best fit for each patient as they come through the door. So depending on which clinician or type of service the patient is earmarked for, it could be anywhere from 8 months to 12 months on top of the initial 6. So 14 to whatever, 16 months wait from the time they give us a call.
Right, or briefer if we pull in Kel.
Yeah.
For the addictions piece or the
That's
trauma
right.
piece. Yeah. Yeah. And again, that's going to decrease dramatically once we're able to expand in the new space and double our capacity. So it's terrible right now. I mean, it's just tragic right now, but we look forward to the not too distant future when we'll be able to get rid of that wait.
Yeah.
And what was the second part of that question?
The second part of the question is, how do you triage your intake?
How do we triage? Well, right now it's a little bit informal and subjective. We hope with the new measurement-based care platform, we can make it a little bit more, it's not exactly objective because the data is still coming from the patients themselves, but more reproducible, more uniform from patient to patient. So I think we're going to actually improve our triage process tremendously when we get that measurement-based care platform.
Excellent, thank you. Another question, what age of people tend to use FEMAP most often? Is it more teens or mid-20s? Does this differ between male and female patients?
So the average age of the person who comes here is 19 and a little bit, 19 years and a couple months. And we know that from our data analysis of that's the average age. However, it is a range. And it does tend to be shifted a little bit more towards the younger age. And in terms of the gender, well, I mean, obviously, because 16, if it's a 16 to 25-year-old range, 19 isn't dead in the middle of that, right? It's a little bit on the younger side of things. In terms of the gender, it's about 60%, 30%, 60% females. And that's consistent with the fact that mood and anxiety disorders are more common in females.
All right, thank you. Another question we have, what would qualify a patient to receive brain imagery testing?
So I think it's important to understand that brain imaging isn't really testing per se. It's part of research protocols. So they would have to meet the criteria for the research protocols. And so right now we're looking at a research protocol that involves early adolescent nicotine use. And so that would be people who have had extensive nicotine use in their 12 to 17-year age range. And so that they would be invited to participate in a research study looking at brain differences in people who had early nicotine use versus not. And that's all completely voluntary.
Excellent. The last question, when will the program being brought in from Australia start?
So we are hoping to get that up and running by September. We're not sure we're going to meet that deadline. The fact of the matter is that the Alberta government has begun this software platform across their entire province. And so, that started about 2 years ago. So the good news is we've been able to leverage some of their early work, getting that through a Canadian system. And so that actually really makes the process much faster, we hope. But there are a lot of legal details involved in terms of confidentiality and privacy and that sort of thing. So there's some hoops to jump through on the legal sides of things, and that's going to be the rate limiting factor for sure. Although I should say that we are still raising money for that as well. So that's going to be critical for that.
Absolutely. Well, thank you. And I believe that is all of the questions that we have at this point. But of course, everybody joining us today, we do invite you following the tour. If you do have additional questions, everyone is welcome to reach out, and we'd be delighted to provide you with whatever information you need. So with that, we'd really like to thank our incredible team at FEMAP for your time, for your presentations today. It's clear, the team is so passionate about the work that you do every day. So thank you so much for sharing your expertise with our donors and our partners here today. To you, our donors, thank you. Thank you for your inspiration to invest in this program. Everything you've seen and heard today would not be possible without you. Many of you know that we are currently in a $4 million campaign for FEMAP's expansion to help treat as many youth as possible. So we're $1 million away from our goal of being able to expand FEMAP services to give youth this, the very best care possible. So we're grateful that you joined us today to see firsthand. We hope you find it inspiring and informative, and most importantly, to see the impact that you're making. Donor support is vital to everything that we do, so thank you. And so that concludes our tour, and we wish you and your families a very healthy and happy summer ahead. Thank you so much.